After treatment of acute ischemic stroke, MRI is routinely performed to look at the extent and volume of the infarct and any hemorrhagic transformation. But what other information may be sitting on that same scan that could speak to the prognosis of the patient? To discuss this, I'm joined today by my colleague at Hopkins, Dr. Cynthia Greene. She's going to be discussing her article in the latest issue of AJNR entitled Posttreatment Follow-up MRI Imaging Biomarkers of Collateral Status are Associated with Short-Term Outcomes in Large-Vessel Acute Ischemic Stroke. Welcome, Cynthia.
Thank you for having me here.
So this is an effort with the senior author Vivek Yadavalli, one of our other colleagues at Johns Hopkins, who has done a lot of research with stroke outcomes as they pertain to imaging. Cynthia, could you give us some background for listeners who are not familiar with some of this research going on?
Yeah, so my primary focus here is to look at the MRI imaging data that we get in a lot of our inpatients currently clinically. And so those are post-treatment, post-intervention MRI imaging sequences, and looking at, is there something that we can glean, a biomarker that can portend short-term outcomes and complications in these patients? So the vast majority of them are, the ones that we investigated particularly here are anterior-circulation, large-vessel occlusion, ischemic stroke. And we looked at patients who were all comers, so like all treatments, so like either managed medically or managed with intravenous therapy or with mechanical thrombectomy. Within those population, we examined the all treatment cohort, so the entire cohort, and then the sub-cohort of those who were treated with mechanical thrombectomy. We broke that population down into those who were successfully reperfused and examined that population further. Within this framework, we looked at the MRI markers. So the two markers that we were most interested in were the FLAIR hyperintense vessels and the what's called the susceptibility weighted imaging brush sign. So what's interesting about these markers is that they are artifacts. There's things that we normally ignore in imaging, but they reflect something that's actually going on in the brain. So the FLAIR hyperintense vessels are the failure of the flow void to be maintained when we're doing inversion recovery imaging. It's related to slow flow, altered flow that fails to suppress in the sequence. And this is important for stroke because it reflects that there's persistently altered flow within the region of the stroke. It may or may not correlate with the core infarct, but there's been other previous research that uses this as a surrogate for persistent perfusion, and that the actual burden of these abnormal vessels reflects the persistent perfusion abnormality. And that's one of the signs that we're going to use to analyze the relationship between this marker and the post-clinical outcome. The second one, the SWI brush sign, is the appearance of these deep medullary veins. So these medullary veins appear more intense on susceptibility weighted imaging because of the concentration of deoxyhemoglobin. So it's the paramagnetic nature of the hemoglobin due to the decreased oxygenation. And so this is more of a venous marker. So it's a reflection of what's going on with the parenchyma and also the venous outflow within the region of perfusion. So these are the two markers that we're using to try to tease out what's going on. These have both been previously investigated in pre-treatment MRI and shown to have actually controversial relationships between both short-term clinical outcome and also complication rates in patients. Controversial in that, like, the papers and projects have previously shown that both there are positive relationships, so patients who have some FLAIR hyperintense vessels have better outcomes, and then on the other side, patients who have FLAIR hyperintense vessels and this brush sign have worse outcomes and worse rates of hemorrhage. So part of our work here is, can we use both of these signs to help us understand the relationship between these markers and outcomes and in different patient populations?
And for viewers of the video version of this podcast, you can check out the figures that we're displaying here on the screen. So once again, we're talking about the FLAIR hyperintense vessel sign, where you have the lack of a flow void in a PL vessel. So here we have a left MCA infarction, and a distal MCA vessel here appears as a hyperintense vessel within the distal part of the sylvian fissure. And then on the next slide, the susceptibility brush sign are engorged intraparenchymal vessels that appear like a paintbrush within the region of the infarction. Thanks for that, Cynthia. Can we walk through your methods for conducting this review?
Sure. This is a retrospectively analyzed, prospectively maintained database, comprehensive database across our JH system, which is maintained by Vivek Yadavalli in terms of all this data. And so the two cohorts we gathered within the time period were 273 patients with MRI data obtained during their inpatient hospital stay. Within this cohort, there were 181 successfully reperfused patients who underwent mechanical thrombectomy. And then these were the two main cohorts that we analyzed. We looked at their clinical data, the NIHS scores, anticoagulation, and other clinical factors, including the infarct volume that we obtained from the MRI as well, because these are all known factors that are related to outcomes within stroke, in addition to our MRI signs. I guess I should also explain the FLAIR hyperintense vessel score. So it's a qualitative assessment of the actual burden of the FLAIR hyperintense vessels, and it's calculated based on vascular territory, both anterior, middle, and posterior circulation, and where the MCA is split into 4 regions. Each of the regions is scored, and the total FLAIR hyperintense burden is given a score from 0 to 12, depending on the number and distribution of vessels. We use this to give more nuance to the actual burden of the perfusion abnormality, and this is what has been previously shown to be related to the perfusion abnormality in the brain. That, in conjunction with the brush sign, are what we used as our MRI biomarkers. We performed a logistic regression to assess the relationship between the scores, the clinical outcomes, the clinical factors, and short-term clinical outcomes. Our short-term clinical outcome is improvement in that NHSS score from admission to discharge greater than 4, which has previously been shown to be related to positive clinical outcomes in patients. The other was looking for any signs of hemorrhagic transformation afterwards. And so it's either a 1 or 0 positive for any petechial hemorrhage or parenchymal hemorrhage by the ECAS-2 scoring system.
So to summarize that, I want to make clear, you have your independent variables that you're examining, which include this NIH FLAIR hyperintense vessel score. The higher score means more hyperintense vessels, right?
That's right.
And you also looked at the presence of the susceptibility brush sign. And your dependent variables are NIH stroke score shift of at least 4.
Yes.
And hemorrhagic transformation.
Yes, that's binary outcome. Thank you, Francis.
Thanks for the discussion about the methods. So let's now talk about the results. You did a regression analysis looking at whether these MRI biomarkers were associated with outcomes on the NIH stroke scale or the presence of hemorrhagic transformation. Can you walk us through these tables and figures?
Absolutely. So in these first cohort that we examined, remember, these are the patients who were treated with medical therapy, intravenous therapy, and also mechanical thrombectomy, regardless of reperfusion. We found across the population, NFS was able to independently predict outcomes, so worse outcomes for NIHS shift greater than 4, and it was also able to predict the risk for hemorrhagic transformation. Interestingly, the greater burden that you have of FLAIR hyperintense vessels decreases your odds of having a good outcome. So there's approximately a 36% decreased odds in having a good outcome if you have a greater burden of FLAIR hyperintense vessels. Conversely, if you have the FLAIR hyperintense vessels, you actually have a decreased risk of hemorrhagic transformation in the post-treatment setting. So in the graph where we have the area under the curve, the logistic regression, ROC, you have the blue curves, which are the predicted outcomes for NIHS shift, and the red is for blood, for hemorrhagic transformation. The solid curve is when we're using both the FLAIR hyperintense vessels and the brush sign to predict outcomes in addition to clinical factors, counting for clinical factors. And the dotted line is with clinical factors alone and the infarct volume. And so we show that we have an incremental improvement in our ability to predict NIHS shift and also our ability to predict hemorrhagic transformation within this group, showing that we're adding additional information that we as radiologists can identify within these patients.
It's very interesting from a clinical practical standpoint to know that these are pieces of information that we can extract from the images that could shed light on the neurologic prognosis moving forward for these patients. It's not just about describing the location of an infarct. They already know there's an infarct. We should want to, number one, quantify the volume of the infarct. And number two, look for these biomarkers, right?
Precisely, because very often we are doing these MRIs to further characterize this stroke, the actual core infarct. But in addition to that core infarct, collaterally, we're getting this information that can tell us a little bit more about outcomes that we may not get all the time or may not observe directly.
You also looked at the subset of patients that were successfully reperfused after thrombectomy, right?
Exactly. And so this is a graph demonstrating the frequency of these signs. So even though the patient was successfully reperfused, MTQ score 3, we still observe FLAIR hyperintense vessels and these brush sign in fewer of these patients. There are the majority of the patients who went to mechanical thrombectomy were successfully reperfused. So the frequency here is the number of cases where we observe FLAIR hypertense vessels. Even in cases where there are many successfully reperfused patients, we still continue to see FLAIR hypertense vessels and the brush sign. And so the question here is, does that mean anything? Did we observe similar trends? And so we did our same logistic regression analysis here as well to examine the relationship.
So you're saying that after the thrombectomy, the angiographer saw that there was complete reperfusion of the ischemic territory, but then on the follow-up MRI, you're still seeing FLAIR hypertense vessels, which suggests that the very distal vessels are still slow flowing, right?
Correct.
So what did you find in your subset analysis for the logistic regression?
Thank you very much. And so again, this is the subset of patients who are all successfully reperfused, so MTQ score 2B or greater. And within this population, we continue to see a relationship between the burden of the FLAIR hypertense vessels and short-term clinical outcomes. So here, the blue curve is still our short-term clinical outcomes, and the red is hemorrhagic transformation. And we see the same thing. So the increasing burden of FLAIR hypertense vessels portends a worse outcome. There's decreased odds of having a good outcome and increased NHS shift. And on the flip side, in this particular population, there's a trend that we observed before, but it's no longer statistically significant. But in our RC curve analysis, we still have an incremental improvement on the observation of these outcomes in addition to the clinical scores. We have to also remember that this population is a little bit smaller than the whole group. And also, unlike the larger population, the FLAIR hypertense vessels here are observed less frequently, which is understandable because these patients are successfully reperfused. So these trends were harder to tease out. There's much more noise here.
Thanks so much for explaining the results to us, Cynthia. Do you have any take-home points for our listeners?
Yes. And so within this population, we're observing macrovascular changes on MRI, both in the cortical arteries and also in the cortical veins. This combination of findings are related to outcomes, both in when we're looking at the post-treatment population across stroke patients, so all medical, intravenous, and mechanical thrombectomy. And then in the subcohort of patients who are successfully perfused, we're continuing to observe independent predictive relationship between the burden of FLAIR hypertense vessels and short-term clinical outcomes. And this second population is particularly interesting because within successful reperfusion, we're also concerned about what's called the no-reflow phenomenon. And we hypothesize that this macrovascular persistent perfusion abnormality may also reflect some of this microvascular perfusion abnormality that might be reflective of this failed thrombectomy or no-reflow phenomenon that is observed in these patients.
Well, I'll definitely make sure to look for these macrovascular MRI biomarkers of perfusion abnormality on future MRI for stroke post-treatment follow-up. Do you have any thoughts about future directions for research in this area?
Yes. So our primary work here was on sort of qualitative and sort of assessing the burden across MRI imaging. The next step really is to relate perfusion measures to begin to quantify like how much of this factor that we're observing is related to persistently altered perfusion, both in the successful thrombectomy population and also across stroke patients.
Wonderful. Thank you so much for joining me on the podcast today, Cynthia.
Thank you very much, Francis.